Hi, I'm Sharon Adler. I'm a nephrologist and investigator at the Lundquist Research Institute at Harbor-UCLA Medical Center and a professor of medicine at the Geffen School of Medicine at UCLA. And I thank you for joining us. And we're going to talk now about the current IgA nephropathy treatment landscape. Here are my financial disclosures. The learning objective is quite simple. We're going to discuss the core components of how IgA nephropathy is currently treated. So KDIGO 2021 has a management algorithm, which in general is quite true, but in particular is being modified. The generality is that low-risk patients who are not at risk for progression should get supportive care. And high-risk patients should get supportive care and immunosuppression. But things have changed because we have new supportive care drugs available to us that were not available in 2021. And we have a new immunosuppression agent that was not available, and new data regarding the safety and efficacy of orally absorbed steroids, so that low-risk patients should get supportive care, high-risk patients should get supportive care and immunosuppression, but our tools have changed so that the management issues for KDIGO are under revision. Let's talk about non-immunosuppressive approaches. Basically, we want to take a non-immunosuppressive approach when there is low progression risk, and our supportive care targets proteinuria and control of blood pressure. So we have lifestyle interventions, sodium restriction, moderate protein restriction, a heart-healthy diet, targeting ideal body weight, exercise, smoking cessation, and reduction of alcohol if it's excessive. And on the medication side, we have RAAS inhibition, diuretics, non-dihydropyridine calcium channel blockers, and new agents, endothelin antagonists, and SGLT2 inhibitors. So let's talk about ACE inhibitors and ARBs. These have been available to us for more than a decade, and a KDIGO 2012 meta-analysis of randomized clinical trials show that RAAS inhibition was of great benefit to patients with IgA nephropathy, and this has been a cornerstone of treatment strategy for about a decade or slightly over. So ACE inhibitors and ARBs are the foundation of treatment for patients with IgA nephropathy, but we now have new agents. We have endothelin antagonists. So endothelin is emerging as an important vasoactive molecule because it's activated by chronic kidney disease morbidities, and inhibiting it has important downstream anti-inflammatory and anti-fibrotic actions. So by inhibiting endothelin A receptor, we get benefits at the vasculature, on podocytes, at the renal tubules, in the mesangium, and we reduce inflammatory cell tissue inflammation, all of which reduces chronic kidney disease progression. So an agent called sparsentan, which is an endothelin A antagonist covalently bound to an angiotensin receptor blocker, was tested in a phase 3 clinical trial. And it was approved a couple of years ago by the FDA by a new proteinuria surrogate accelerated approval process, because sparsentan was shown to reduce proteinuria by almost 50% compared to the patients getting an active control, irbesartan, whose proteinuria decreased only 15%. So this difference in proteinuria reduction, 50% compared to 15%, resulted in an accelerated approval for sparsentan for IgA nephropathy. But the FDA's accelerated approval process also required a 2-year eGFR benefit confirmation. And when this was assessed, sparsentan just missed the p-value of 0.05 by a whisker The EGFR total slope did definitely decline um, um, less in the sparsentan group. The decline was a slope of 2.9 compared to the irbesartan group where the decline was 3.9, but the p-value was 0.058 instead of 0.049. So sparsentan did not receive its final approval yet. It is still being marketed under the accelerated antiproteinuric approval, which was the accelerated approval. And the supplemental new drug application was submitted in March to try and reach the EGFR reduction requirement by the FDA for full approval. Another way to use an endothelin antagonist is to use it naked without an angiotensin receptor blocker covalently bound to it. And the atrasentan studies are looking at endothelin antagonism from that point of view. Interestingly, atrasentan alone looked pretty similar, with reductions of proteinuria at 38% at 6 months, 48% at 12 months, and almost 55% at 24 months. And it's been reported that the phase 3 ALIGN trial of atrasentan and IgA nephropathy met its proteinuria target. Formal data is to come, and the study is ongoing for its EGFR outcome. So we have ACE inhibitors as foundational. We have endothelin antagonists, both bound to an ARB, which are available now, and naked, which are undergoing FDA review. And now we also have SGLT2 inhibitors. We know that SGLT2 inhibitors were originally developed for diabetic kidney disease, but they've also been studied in non-diabetic chronic kidney disease. Reports of this were available in the New England Journal in the DAPA-CKD study. SGLT2 inhibition works by inhibiting sodium glucose cotransport in the proximal tubule, resulting in both sodium and glucose flooding the macula densa. Sodium and chloride reach the macula densa and causes afferent arteriolar vasoconstriction, reducing intraglomerular hypertension and protecting the glomerulus. The DAPA-CKD study had 270 patients with IgA nephropathy, and the results of those patients were reported separately and were anticipated in advance to undergo separate analysis. And what we can see is that patients receiving DAPA had less primary endpoint reaching than the placebo patient. So the primary composite endpoint in the DAPA-CKD study was a sustained decline in EGFR of at least 50%, end-stage kidney disease, or death from a kidney disease or cardiovascular disease. And those adverse events happened substantially less in the DAPA patients than patients getting placebo. The renal endpoint, which was similar, except it didn't include cardiovascular death or adverse events, were also better in the DAPA group than placebo. The difference between graphs A and B and graphs C and D here, which otherwise look identical, is that there were a few patients, less than 10 in each group, that were entered as IgA nephropathy patients, but who didn't have a kidney biopsy. But the results are exactly the same, and IgA nephropathy data were as strong as the diabetic kidney disease data. So that SGLT2 inhibitors in particular, because we can see the DAPA data, DAPA is a good choice for patients with IgA nephropathy. And emerging data suggests that SGLT2 inhibitors reduce inflammation and antifibrotic pathways as well, and do not just cause a decrement in intraglomerular hypertension as its mechanism of action. That is certainly the case but it also decreases systemic blood pressure by reducing sympathetic nervous system activity. It reduces inflammation and fibrosis by reducing inflammatory and fibrotic biomarkers, and it reduces renal ischemia by reducing renal hypoxia. So SGLT2 inhibitors have emerged along with endothelin antagonists and ACE inhibitors as really foundational in the treatment of IgA nephropathy, barring any individual contraindications for any of these drugs. In addition, under investigation, we have finerenone, which is a non-steroidal aldo antagonist, and other antifibrotic agents. But if I was going to ask for my personal wish about how I want to treat high-risk patients, I would want to get at the hits 1, 2, and 3, where we're dealing with undergalactosylated IgA and the antibody to it and the development of circulating immune complexes. And certainly the agents that we have just been describing don't do those things. So what are our options for patients who still have a lot of proteinuria despite maximization of supportive care? We have immunosuppression. And mycophenolate mofetil has been described in a Chinese population as being beneficial. This study in Chinese patients had 170 randomized patients. Blood pressure was well controlled. Proteinuria was more than 750 milligrams a day after a losartan run-in. The GFR ranged between 30 and 60, and the groups were well balanced in gender, age, body mass index, blood pressure, serum creatinine, eGFR, proteinuria, microscopic hematuria, hyperlipidemia, and morphology. And what you can see is that the MMF group did better than the standard control group in terms of the composite outpoint, in terms of eGFR decline, and in terms of proteinuria. So in this Chinese population, MMF was a valuable agent for high-risk patients. However, the data supporting MMF in non-Chinese populations are lacking. So we need something else for non-Chinese patients. We have used systemic steroids for many years. This is a meta-analysis of randomized clinical trials showing that the doubling of serum creatinine is less frequent in patients receiving steroids with a RAAS inhibitor versus those receiving RAAS inhibition alone. And so the KDIGO 2012 glomerular disease set of references advocated for steroids. Since then, there have been two major studies looking at steroids, which is the Testing 1 trial in predominantly a Chinese population, and the Stop IgA Nephropathy trial, which was in a German population. Testing 1 looked at patients with a lot of proteinuria, mean proteinuria almost 2.5 grams a day, and looked at corticosteroid benefit and risk. They used a dose of methylprednisolone of 0.6 to 0.8 milligrams per kilogram per day, up to 48 milligrams for 2 months, and then tapered with a total treatment period of 6 to 8 months. They showed benefit, but the study was stopped early due to safety concerns, including serious infections and 2 infection-related deaths. In the German population, steroids were shown to confer partial benefit. It induced good antiproteinuric effects, but no long-term beneficial effects on eGFR. So that left a bit of a quandary. The Chinese investigators altered the Testing 1 methylprednisolone dose, hoping to maintain the benefit while reducing the risk. So they lowered the dose of methylprednisolone to up to 0.4 milligrams per kilogram per day, up to 32 milligrams per day for 2 months, then tapered for a total treatment period of 6 to 9 months. And what they demonstrated was that they preserved benefit. The primary outcome occurred significantly less frequently in the methylprednisolone group compared to the placebo group, and there was a reduction in adverse events, but serious infections still occurred. So, where are we with steroids? That is systemic methylprednisolone or prednisone. I think it can be said that systemic glucocorticoids may still be an option for some patients with IgA nephropathy who are at high risk of progression, but that there may be incremental benefit in Chinese patients compared to non-Chinese patients, and there's still some systemic risk, particularly in the realm of infections. Enter targeted release budesonide. Targeted release budesonide is a steroid that's been modified by a special coating that results in release of the steroid at Peyer's patches in the GI tract, where you may recall the undergalactosylated IgA B cells are generated, so that there's targeted release where the antigen is actually generated. And the idea is that if we target our steroid to the GI tract, that we will have less translocation to bone marrow and less antibody synthesis and less circulating immune complexes and less proteinuria and better preservation of EGFR. So, what did the clinical trial show? It showed exactly that. The proteinuria was less in the patients receiving targeted release budesonide. And interestingly enough, you can see the proteinuria declined at 9 months by 27% in the treated group. And at 12 months, 3 months after in this trial the drug was stopped, there was even more proteinuria reduction. And that was true of UPCR and urine albumin creatinine ratio. Interestingly enough, with regard to GFR, in the first few months, there was a increase in GFR of about 4 or 5 mils per minute per 1.73 meters square, and that increment in GFR was preserved over the course of the trial. So patients getting targeted release budesonide had a substantial decrement in proteinuria and a preservation in GFR. The proteinuria and GFR benefits that budesonide offers are accompanied by exactly the kinds of benefits we want to link to pathogenesis. We can see that budesonide reduced galactose-deficient IgA1 and reduced IgA, IgG immune complexes, demonstrating effects on hits 1, 2, and 3. Budesonide was overall well tolerated, but there may have been a trend towards somewhat more adverse events in the treatment group. There were no infectious deaths, but there was 4 times as many drug discontinuations in the budesonide group compared to placebo, twice as many emergent serious adverse events, 1 COVID death and 1 cerebral hemorrhage, not thought to be directly related to budesonide, but 4 times as much edema, 4 times as much hypertension, 3 times as much muscle spasms, 11 times as much acne, and an equivalent amount of headache, infections, and infectious and serious adverse events, which were somewhat more common in budesonide than placebo-treated patients. So, targeted release budesonide is now the first FDA-approved steroid for IgA nephropathy and the first fully approved medication for IgA nephropathy, having met both the proteinuria reduction goal and the GFR preservation goal. So we have systemic steroids and we have targeted release steroids. And despite these new therapies, patients at risk are still progressing. In view of the current uncertainty over the safety and efficacy of current immunosuppressive treatment choices, all patients who remain at high risk of progression despite maximal supportive care should be offered the opportunity to take part in a clinical trial. So we're going to pause and ask you a question. Which of the following have been shown to reduce serum galactose deficient IgA1 and IgA-IgG circulating immune complexes in IgA nephropathy? And we do have the data for targeted release budesonide with regard to reduction in the antigen and the circulating immune complexes. Now, there are lots of clinical trials ongoing. There are BAFF/APRIL inhibitors, complement inhibitors, plasma cell inhibitors. And if you go to clinicaltrials.gov, we can see that there are 69 completed clinical trials in IgA nephropathy, 16 active trials that are not currently recruiting, and 14 recruited trials. So there's a lot of activity and a lot of potential for new drug development in this space. So I can say with some optimism that for patients with IgA nephropathy, we do see a brighter future ahead. Here are some additional readings and resources. And thank you very much for attending this clinical trial and clinical perspective overview. Thanks from the National Kidney Foundation.